Hello students, I'm Dr. Shamla from Department of Orthodontics. Today we are going to learn about basic concepts of occlusion and do 6 keys and index of orthodontic treatment need, which is your IOTN. So today's class we will be learning about what is occlusion, what is malocclusion, and what are the concepts of normal occlusion. We will also be learning the classification of different types of malocclusions and advantages and disadvantages, the various types of cusp which is important for occlusion, and also the Andrew 6 keys to achieve a normal occlusion. So first and foremost, what is an occlusion? To be a very simple term, an occlusion is a normal relation of the occlusal inclined planes of the teeth when the jaws are closed. This definition is very simple and clear, given by angle, right? Now, what are the basic terminologies which are used in occlusion? These are very important, right? You must know these terms. First and foremost, what is an ideal occlusion? Okay, the concept of ideal occlusion or optimal occlusion, what they are trying to mean is that it refers to both an aesthetic and physiologically it is ideal, right? So it is aesthetically good looking when you smile and also doing its job, okay, or function. So it includes the three things: functional harmony, stability of your masticatory system, and neuromuscular harmony. So you have your harmony in function, you have the stability of your masticatory system, and also muscle harmony. When you achieve all this, you know that it is an ideal occlusion. So in this picture, you can see what an healthy occlusion looks like, right? So you see here the classic angles class 1 occlusion, okay? And you see the minimal overjet and overbite. This with normal intercuspation, this you can say is as healthy or an ideal or optimal occlusion. Now this over here towards your left is your pathologic or a malocclusion, right? Okay, now there are a few terms here. First is physiologic occlusion. The occlusion that shows no signs of occlusion related pathosis, right? Occlusion related problems. It may not be an ideal occlusion, but of course there are divide of any pathologic manifestations. That is called as physiologic occlusion. Now there is one more term, balanced occlusion, where there is equal contacts, okay, between your upper and lower arch during all the functions of the mandible. There is something called as a functional occlusion, which is defined as an arrangement of the teeth which will provide highest efficient function during your movements of the mandible, right? There is something called as therapeutic occlusion. That means it is a treated occlusion, that is orthodontically you have treated it, right? Now there is something called as traumatic occlusion. An occlusion judged to be causative factors in the formation of traumatic lesions of disturbance in the orofacial complex. Now what is trauma from occlusion? It is defined as an injury to your PDL by any occlusal forces, or you have an abnormal contacts or occlusal contacts because of these forces. Okay, moving on, you must know certain types of cusps which are important in getting a good occlusion, right? First, it can be classified into supporting and non-supporting cusps. Supporting cusps are the cusps which are able, that is, which gives you the support for your mandibular movements, right? And non-supporting cusps are those which helps, like when you are supporting cusp, that when you move the jaw towards the one side, okay, the other side is called as the non-supporting cusp, right? So the supporting cusp basically, okay, this might be your MCQ question or a 2-mark question. So which are called as supporting cusp? The facial cusps of your mandibular, that is this one, right, over here. Okay, facial or buccal cusp of your mandibular and your palatal cusp of your maxillary posterior teeth are called as supporting cusp. Now what are non-supporting cusp? The maxillary buccal, that is this one over here, or facial, and your mandibular lingual, are called as non-supporting cusp. So there is a small acronym which is given here. It's called as BULL for non-supporting cusp. So this can be your MCQ or 2-mark question, right? So buccal of upper and lingual of lower. Now there are a few curves which are very important for you, right? This is your short answers, your MCQs, yes, anything viva which can be asked. Okay, so there are some occlusal curves which are very important. First and foremost is your curve of Spee. Now this is very important. A curve of Spee, which was discovered by Graf von Spee, hence the name, is an anterior-posterior curve, right? That is your anterior to posterior curve, hence the name, right? So don't read this text, focus on what I am going to talk, right? So the anterior-posterior curve starts from the tip of your canine. It follows the buccal cusp of your premolars and molars, right? And then it passes through the anterior border of your ramus of the mandible, right? And ends at the anterior aspect of your condyle, which is this area, right? So this is your condyle and this is your anterior portion. So this is called as curve of Spee. Now there is one more curve called as curve of Wilson, which is an mesiolateral or mediolateral curve, okay, that contacts the buccal and lingual cusp tips of your mandibular posterior teeth, right? Simple. Okay, moving on. Curve of Monson, right? So it is also called as a spear curve, right? A curve which is a combination of a curve of Spee and curve of Wilson, right? Hence the name curve of Monson, right? Okay, so another few important terms is centric relation, right? A centric relation, okay, is a jaw guided or a muscle guided relation, right? That is bone to bone relation, okay? So it is not influenced by teeth or occlusion. So when you swallow and you rest, you see that your teeth are not occluding. Yes, all of you can try to do that and see, right? So when you swallow and see that there is a gap, that is called as a centric relation, to put it in a very simple terms. Whereas centric occlusion is tooth to tooth relation. It is a tooth determined position, that is when you bite. That is called as your centric occlusion, which is also called as intercuspal position or convenience occlusion. That can be your MCQ question. Then there is something called as eccentric occlusion. Here I just wanted you to know the names, right? So there is called something in eccentric occlusion, which is any occlusion relation other than your centric occlusion is called as eccentric occlusion. Okay, just know this. So in eccentric occlusion, there are two types, functional and non-functional occlusion. Under functional, you have lateral and protrusive function. Okay, so lateral by the name itself, it suggests what is the position of the mandible, and also protrusive, you all know by now, right? So moving on to the important parts of the topic, Andrew's 6 keys of optimal occlusion. So here is an interesting story behind it. So Lawrence F. Andrews collected 120 non-orthodontic models for 4 years, that is from 1960 to 64, and he compared it with 1150 treated models, right? He studied the difference between the best in treatment results that you have achieved through your orthodontic treatment with the best in nature, right? Which gave birth to 6 keys, how an occlusion or an ideal occlusion should look like. So you don't have to read through the entire thing, okay? Just know the key points, that is more than enough, right? If you write all the 6 keys and maybe a point or two under that, it should be good. So key number 1, inter-arch relation, right? So this key, okay, is basically talking about inter-arch relation, that is relationship of your maxilla to the mandible, right? Intra arch means within the same arch, whereas inter arch means between your two arches, which is maxilla and mandible. So in this, the important points are the mesiobuccal. All of you know by now what is a class 1 malocclusion, angles 1, yes? So this is the thing. So the mesiobuccal cusp of your maxillary first molar occludes in the groove between your mesial and middle buccal cusp of your permanent mandibular first molar. Okay, so this is very, very important when you are writing key number 1. Yes. The second point is the distal marginal ridge of your maxillary first molar occludes with the mesial marginal ridge of your mandibular second molar. So first molar is done here. How the second molar should be, that's given here. Next is the mesiolingual cusp of the maxillary first molar occludes in the central fossa of your mandibular first molar. Okay. The buccal cusp of the maxillary premolars have a cusp-embrasure relation with your mandibular premolars, right? So this is talking about your premolars, right? This is about the buccal cusp. Moving on to the lingual cusp. The lingual cusp of the maxillary premolars have a cusp-fossa relationship with the mandibular premolars. The maxillary canine has a cusp-embrasure relation with the mandibular canine and the first premolar. So the canine has a relation with your mandibular canine and your first premolar, right? The maxillary incisors overlap the mandibular incisors and the midline of the arch. Moving on, mesiodistal crown angulation. Okay, so just write a point or two more than enough. The degree of the crown tip, okay, is the angle between the long axis of your crown and a line drawn 90 degrees from the occlusal plane. So your long axis of your crown and drawn 90 degree from your occlusal plane. If it is positive, okay, it means that when the gingival portion is distal to the incisal position, right? And negative means when the gingival portion is mesial to your incisal portion. What is a labiolingual crown inclination, right? The crown inclination is determined from mesial or distal view. Labiolingual, right? It is formed by 90 degree to the occlusal plane and a line drawn tangent to your bracket site. Okay, so it usually is around 7 degrees as seen in the picture. Okay. Next key is absence of rotation. The fourth key to normal occlusion is that the teeth should be free of rotations. That means, okay, when the teeth are rotated, it acquires more space, as you can see in the picture. Okay, so as you see, when the teeth is rotated, it will acquire more and more space. Right? Imagine you tilting this tooth. Don't you think that there will be 1 or 2 mm of space left here? That is what. So an optimal occlusion should have absence of rotation. Next is tight contacts. So Andrew says that to consider an occlusion as normal or ideal, yeah, the teeth should be in tight contacts. That means there should not be any space, okay, and they should have a tight contact, right? Okay, so as you see in this picture, okay, you see that all the tooth are in tight contact, whereas here you see there is some spacing, there is proclination. Okay, so as we all know that an ideal occlusion should have a normal curve of speed, which is about 0 to 2.5 mm. Now there is a seventh key which is important. It is called as correct tooth size. Okay, that is Bolton's tooth size ratio, right? All of you have learnt about the Bolton's analysis in your model analysis lecture. So Bolton's tooth size ratio is considered as the seventh key of occlusion, so that the tooth size of the maxillary and mandibular arch should match the proper overjet and molar relation without any spacing or crowding. Now moving on to what is an IOTN, that is Index of Orthodontic Treatment Need. It is a measure for the necessity of orthodontic treatment. It combines both physical and aesthetic measures. Okay, so basically it is used to assess the need for children under 18 years of age whether to go for orthodontic treatment or what, right? So IOTN is an objective and reliable way for specialists to select those children which will benefit well with for your orthodontic treatment, okay, if you have any remote or limited resources. So just a brief history, it was developed by Brook and Shaw in the year 1989. So it comprises of health component and aesthetic component. Okay, so this is the classification. I want you all to read through it, whereas I'll be going in detail in the next slide. So listen very carefully here, right? So under dental health component, if they say grade 1, that means no need for treatment. Okay, that means the malocclusions are very minor and displacement or anything is less than 1 mm. Okay, so not very much need there is for orthodontic treatment. Now grade 2 are subdivided into a lot, right? So under grade 2, there is that basically is little need for treatment, right? So they have classified, okay, so which malocclusion and how much it should be to come under grade 2. So 2A means there is an overjet, okay, of about 3.6 to 6 mm, but the lips are still competent, okay. So overjet is not that much where there is severely, gummy smile or gum exposure. Now 2B means reverse overjet, right, of about 0.1 to 1 mm of reverse overjet is seen, right. Now 2C means anterior or posterior crossbite with only just minor 1 mm of discrepancy. That means little need for treatment. Grade 2, 2D, okay, that means displacement of teeth, okay, about 1.1 to 2 mm, okay, so a minor displacement, right? Okay, 2E, anterior and posterior open bite. You see here open bite where the maxilla and the mandibular teeth are not occluding, right? Okay, so if the open bite is about 1.1 to 2 mm, that comes under grade 2, that is 2E. Okay, next is 2F, that means increased overbite, right, of about 3 mm or 3.5 mm or more, okay, without any gingival contact. When I say increased overbite, we are talking about deep bite, okay. So I think by now you are very familiar with overbite and overjet, right? Okay, 2G is half unit discrepancy in molar occlusion, okay, that is in the molar occlusion, okay, there is half mm. That means it might end up in an end-on class, okay, or a super class 1, right, without any other malocclusions. Everything looks perfect except for about half unit discrepancy in the molar. Now, moving on to grade 3, where you require moderate need for treatment, right? So you require some treatment. Under this, we have different subheadings. Let's see one by one. So in grade 3, okay, we have 3A, that means increased overjet. Yes. So the increased overjet is about 3.6 to 6 mm with incompetent lips. So when you see incompetent lips, as you see in this picture here, yes, incompetent lips, okay, with increased overjet, right? Okay. 3B, that is reverse overjet of about 1.1 to 3.5 mm. 3C, which means anterior or posterior crossbite with about 1.1 to 2 mm of discrepancy, right, as you see in this picture. 3D means displacement of teeth, okay, that is about 1 to 4 mm. 3E means lateral or anterior open bite. Okay, that means about 2.1 to 4 mm. 3F means there is an increased or complete overbite. Okay, there is a complete overbite, but still there is no gingival trauma. Okay, about say half to 1 mm of gap is still there, right? Okay, so moving on to grade 4, which is the great need for treatment. Yes, so grade 4, right? So definitely you require treatment. So what are these cases? So 4A means increased overjet, which is about 6.1 to 9 mm. Yes, so 6.1 to 9 mm, right? With incompetent lips. Next is 4B, which is reverse overjet greater than 3.5 mm with no masticatory problems as such, but aesthetically definitely there is a problem over here. 4C means anterior or posterior crossbite with greater than 2 mm discrepancy. 4D means severe displacement of teeth, like you see in this picture, greater than 4 mm. 4E means extreme lateral, right? Extreme lateral or anterior open bite, which is definitely greater than 4 mm. 4F means complete overbite with gingival trauma. Now, I hope you all have seen the lecture, and by now you must know which grade and which under which subheading is complete overbite without gingival trauma. So take a minute and brush up. See if you know by now. If you know, very good. If you don't, please go back to the slides and see, right? So 4H, hypodontia, requiring pre-restorative orthodontic space closure to avert need for prosthesis, right? So I hope you all know what is hypodontia, right? So what is 4L? Posterior crossbite with no functional or occlusal contact in one or both buccal segments. Okay, so there is no occlusal or functional contacts in the buccal segment, right? So that is called as 4L. What is 4M? Reverse overjet, okay, with about 1.1 to 3.5 mm with masticatory and speech difficulty, right? Now 4T is partially erupted teeth, tipped, impacted against the adjacent teeth, right? As you can see in this picture over here, right? 4X, supplemental teeth, okay? So teeth which looks like a normal complement set of teeth, but it is not, okay? It's called as a supplemental teeth, as you can see here. Moving on to grade 5, very great need, okay, for orthodontic treatment in which the orthodontist has to act immediately, right? So that is grade 5. Under 5A, we have increased overjet greater than 9 mm. So that's too much, right? So that comes under 5. 5H, that means extensive hypodontia, lack of teeth. Okay, that is more than one teeth is missing in a quadrant, which requiring pre-restorative orthodontics, right? 5I means impeded eruption of teeth, okay, with exception of third molars, right, due to crowding, displacement, presence of any extra teeth or supernumerary teeth, retained deciduous, etc. 5M means reverse overjet greater than 3.5 mm with masticatory and speech difficulty. 5P means defects of cleft lip and palate. 5S means submerged, okay, submerged deciduous teeth, right? So this is a table of DHC, that is dental health component, using the missing, overjet, crossbite, displacement of contact points and overbite, okay, so MOCDO acronym to prioritize, okay, different forms of malocclusion, right? So you can go through this chart for easier understanding, right? Okay, so here we have grade 1, 2, 3, 4. Okay, so that means 1, 2, and 3, 4 means no or slight need for treatment, and grade 5, 6, and 7 means moderate or borderline need, and 8, 9, 10 means need for orthodontic treatment. Okay, so as you can see in the picture. Okay, so I hope you all understood the basic concepts and theories. Okay, the keys for Andrew's occlusion and the IOTN. Any doubts, please message a private message in ePortal for me to clear. And I hope you all are safe. Okay, and take good care of yourself, right? Advice and take care, and let me know for doubts. Thank you, everybody. Stay safe. So for sorry